Good evening and welcome to tonight's Wu University webinar, Glaucoma Diagnosis, Current and New Technology with Dr. James Fanelli.
Okay.
I'm your host, Dr. Jennifer Stewart. It is my great pleasure to introduce Dr. Fanelli, who's originally from suburban Philadelphia and attended the Pennsylvania College of Optometry, where he graduated in 1985. He's been in private practice since that time in coastal North Carolina, specializing in ocular disease management. He's lectured around the country at state and national meetings on a wide variety of topics, dealing primarily with advanced diagnostic and therapeutic modalities. He's developed a course for certifying ODs in the use of injections in primary eye care that has been used by several states and which was required for licensure renewal of North Carolina optometrists. He's a contributing editor for Review of Optometry and is the author of the bi-monthly Glaucoma Grand Rounds column. He's the past president of the North Carolina State Board of Examiners in Optometry. He's also a past trustee of the North Carolina State Optometric Society, where he served as continuing education chairman. He served as chairman of the iSki Optometric Conference and the CE in Italy Conference, which is on my list. He's an adjunct faculty member of the Pennsylvania College of Optometry. With that, I want to welcome you, Dr. Fanelli, and we can't wait to learn from you.
Thank you, Dr. Stewart. I appreciate that very much. And I'll go through my financial disclosures in a bit. I can tell you I'm in Italy right now, so it's about 2:30 in the morning. I appreciate everybody else being there. Hopefully, you'll get a good night's sleep. I'll get one in a bit. All the financial relationships have been mitigated. This is the COPE course number for this particular event, Glaucoma Diagnosis, Current and New Technologies. Now, it's tough to talk about a lot of things that are going on in glaucoma condensed into a 1-hour lecture. So I want to specifically talk about some of the certainly new technologies that are out there, some of the new thought processes that we need to consider when we're dealing with patients either making that initial diagnosis of glaucoma or the age-old problem that we have once we've made a determination that the patient has glaucoma. For example, are they getting worse? How do we know if they're stable? What can we do to help sort out fact from fiction from some of the things that we see on our OCTs, and how can we make this clearer? So a couple of disclosures. Number one is that I'm in a private practice, and the majority of what I do is either neuro or glaucoma. And the OCTs, we've got a couple of OCTs that we're running in the office, and the majority of the OCT images that you're going to see in this particular presentation are Heidelberg Spectralis images, and I am on their advisory board, but I use this instrument rather extensively in the office. So there's no bias in that. It's just that I'm pulling these slides from cases from clinic, and the majority of them will be Heidelberg slides. So there really are no conflicts of interest. And as I said, all relevant financial relationships have been mitigated. So the first thing we need to talk about, when we talk about glaucoma, we talk about structure. We're using our OCTs. We talk about visual field units from a functional perspective, but we really need to know what our technology is. And this is more aimed at the OCT end of the equation. And without belaboring the point, we have to understand exactly what our technology is doing for us, but we also have to understand what our technology is not necessarily doing or what it's not telling us, and where do we move from factual information to inferred information. So understanding what our technology does not do is frankly just as important as understanding what it does. Now, one of the things that we see across all platforms of OCT technologies are these reference databases. And the reference databases are these red and yellow and green scales that are superimposed on some data points that are picked up during OCT imaging. And these data points, as we see in this particular slide, can be representative of the perioptic RNFL circle scan. We can have reference databases for macular thickness, in particular ganglion cell layer thickness. We can have reference databases related to the neuroretinal rim. But we have to keep in mind that reference databases do, in fact, have some limitations. So let's take a look at this real quickly. This is an RNFL circle scan, and there's a couple of ways that this can be presented. Initially, with OCT technologies, this was a T-SNP graph, meaning that the scan was initiated temporally. The data was calculated upon, in this particular situation, a clockwise fashion around the optic nerve from temporal, superior, nasal, inferior to temporal, and that was then graphed out. As we see here, this is not a T-SNP graph, this is an N-STIN graph, which simply means that the scan was initiated nasally, and then in this particular eye is running counterclockwise. Now, there are some advantages to an N-STIN graph. So some OCTs are going to have T-SNP graphs, others are going to have N-STIN graphs. The advantage to an N-STIN graph is that when we get right down to it, the majority of glaucomatous damage is going to be occurring on the temporal aspect of the optic nerve. And with an N-STIN graph, the temporal aspect of the optic nerve is in the very center of this flat plot that we see here. And the advantage is that we can see that all of the information related to glaucoma is here, whereas if we were dealing with a T-SNP graph, some of it is over on this side and some of it is over on this side. So that's why we're moving more toward N-STIN graphs on a regular database. But we need to keep in mind, as far as reference databases are concerned, is that these are simply statistical measurements. And these measurements all fall under bell curve, the normal distribution of whatever parameter we're looking at. So this particular parameter could be RNFL thickness, as I said, it could be ganglion cell layer thickness. This could be the height of the average person who's sitting in on this webinar. And if we look at this from a height perspective, take glaucoma out of the equation at all, we're going to find that the majority of patients who are sitting in, or the majority of our participants sitting in this meeting, are going to have an average height that's going to fall within the center portion of the bell curve. So let's say that individuals who are shorter are on this side and individuals who are taller on this side. There's going to be fewer very, very tall people in this group. There's going to be few very, very shorter individuals in this group. But this same analogy is used for RNFL thickness. The point being is that when we look at reference databases on our OCTs, our eyes are naturally drawn to this red, this yellow, and this green. And the implication is, and it's something that can get us into trouble, is we see red and we say, oh, this patient has a problem. This patient has a disease. Because obviously, if we're looking at glaucoma and red being over here on the left, that's going to typically imply thinner tissue. Thinner tissue is more indicative of glaucomatous damage. But if this was the height of the individuals that are in this webinar, that would be the equivalent of saying that, well, individuals who are shorter have a disease. Not necessarily. That's not the case. It just means that that individual, those few individuals who are very short, or those few individuals who are very tall, it's normal for them. There's not a disease present. And that's the same piece of information that we need to keep in mind when we look at these reference databases. Just because it's green, it's telling us that that patient is falling within the center parameters, the average parameters for this particular metric that we're looking at. Some folks may, in fact, have a very thin neuroretinal rim, or they may have a very thin RNFL, and it may be entirely normal for them. Just because it's being flagged as red, that doesn't mean that there's necessarily disease present. So we have to keep that in mind. And the point here is that reference databases are really just statistical measures. They're comparative measurements, and they kind of tell us where our patient falls into the range of other age-matched, sex-matched individuals who do not have glaucoma. So it gives us a feel for where our patient falls in. the bad news is that sometimes we put too much emphasis on the red in particular, and that's why we've come up with the term red disease. Just because it's red doesn't mean that there's disease present, and conversely, just because the reference database may be green doesn't mean that there is an absence of degree of disease. And let me show you where that kind of comes in into play here. Here's an OCT scan of the right eye, left eye, two different patients. Again, this is a spectralis. This is a T-SNP graph. So we're looking at the perioptic RNFL scan. This quadrant here are basically the Garway-Heath sectors of the optic nerve. So when we look at this, we say, okay, this is all green. That looks great. We've got this red wedge down here in the infratemporal sector. Well, as we know in glaucoma, the earliest areas of the optic nerve and the perioptic RNFL to become involved are the inferior temporal and superior temporal sectors. So our eyes are naturally drawn to this. We see this red flag in this inferior temporal sector. If this is a glaucoma patient that we're scanning or a glaucoma suspect that we're scanning, we're going to be interested in what's happening down here. We're going to be interested in what's happening superior temporally. And when we look carefully at the actual T-SNP graph, we do see in the inferior temporal sector a relatively thinned area of this perioptic RNFL. We should have a double hump, one being superior temporally and the other being inferior temporally. So we do have thin measurements. We do recognize that this particular individual scan falls outside of normal limits. That's why we have this red area here. This is a situation in the upper left-hand corner where 2 and 2 adds up to 4. Now compare and contrast that to the scan we have down here on the lower right. When we look at the Garway-Heath sectors here, we say, oh, well, this is all green. Every part of this every part of this RNFL circle scan is entirely normal because everything is green. And this is where we can get into trouble because that's not the case. If we look very carefully at this superior temporal sector, and in fact, if we look at this particular portion of the scan, we can see a wedge defect here. Well, if the instrument is accurately measuring it and we can see visibly a wedge defect, we may have seen this wedge defect when we're looking inside the eye. Why is this all green? Why is this sector not being flagged as yellow or red? When we look at the actual measurements of the RNFL circle scan, we can certainly see a dip here. So why isn't this red? And the answer is statistics. This defect is in fact here. It's just not deep enough, nor is it broad enough to make this entire sector flag as either yellow or red. So my point being, just because it's green doesn't mean there's not disease. There is disease here. And same thing conversely happens with red. So be careful with our reference databases. The other question I get in a lot of glaucoma lectures is, what is significant change? How many microns of change is significant before we know that this patient is actually progressing in their disease? And here's a baseline scan in the faint gray RNFL, and then the current scan is this darker area. And for the most part, they are superimposed, except for this one area where I've got this notation mark here. And there's a 26 micron drop in tissue. And the question I get is, is 5 microns significant? Is 10 microns significant? The answer is depending upon two things. It depends upon the resolution of the instrument that you have, number one. And number two, it depends upon what you are looking at. As we know, the RNFL thickness varies depending upon where around the optic nerve. It's usually thicker, superior, and inferior temporally. And if we average out overall RNFL thickness, it's about 90 microns thick, usually a little thicker, superior and inferior temporally, thinner elsewhere. But if we have a structure that's 90 microns thick and we have a 26 micron change, that certainly is going to be significant. Whereas if we have a structure that is 200 microns thick. Let's say total macular, total retinal thickness in the macula, and we have a 10 micron change. That may or may not be significant. And the other piece of this puzzle is the resolution of your instrument. So with that said, those are some of the technical aspects we need to get out of the way. So where do we look when we're using our OCTs in glaucoma? We look at the RNFL. We've done that since the advent of OCT technology. We started looking over in the macula, and we'll talk about a couple of different ways to look at the macular scans. But one of the things that we've kind of neglected initially with OCT technology is looking at the neuroretinal rim itself, and that's why we're moving now toward radial optic nerve scans. And we'll go through each one of these just to give you some examples. So here's an updated RNFL series of circle scans of a patient who has glaucoma. Now, each of our instruments takes an RNFL circle scan of a certain diameter, but research has kind of indicated that there are some individuals whose glaucoma initially starts, for example, in the macula, the ganglion cell layer, and as those axons are lost, that damage actually marches its way toward the optic nerve. And there are other individuals who conversely have damage that first shows up closer to the nerve, and perhaps in the neuroretinal rim, and works its way outward. So several OCT instruments are now, instead of using one RNFL circle scan of a set diameter, they're using 3 different RNFL circle scans, one closest to the optic nerve, and then one a little bit further out, and then one even further out. And that is important because that may show us damage at this innermost circle scan that's not necessarily present here. So again, knowing our technology is relatively important. This patient clearly has a significant thinning of the perioptic RNFL, especially in the inferior temporal sector. This particular circle scan is 3.5 millimeters in diameter, so we can see that damage here. If we use the next circle scan outward, which is 4.5 or 4.1 millimeters in diameter, we still see damage there. And we can get a scan that's even further out at 4.7 millimeters in diameter. So there's damage out here, there's damage here, there's damage here. This is consistent with a rather significant wedge defect. If we have a wedge defect that's equally distributed throughout these various circle scans, we should be able to see some changes here at the neuroretinal rim, and we should also be able to see some changes out here in the macula, which we'll get to those. Now, looking at the macula, and in particular the posterior pole, for determining whether or not there's glaucoma or how much damage there is, there's a couple of different ways that we can look at this. We can look at total retinal thickness, which is what we're looking at here. This is an 8x8 grid of total retinal thickness. This is an individual with rather advanced glaucoma. So this is about as plain as we can see. And we can see some normal thickening around the fovea in the foveal avascular zone, but we can see this piece that seems to be missing here. And notice the total retinal thickness in this inferior hemisphere is, there's definitely more damage, more thinning here than in the comparable superior hemisphere. So this is looking at total retinal thickness. Here's another individual with a bit of a wedge defect, and I think we can all appreciate the fact that there's a wedge defect, but we can also see this thickening here, and this thickening is due to an epiretinal membrane. If we look at this from just the perspective of the ganglion cell layers, okay, this is going back to the previous slide, this is total retinal thickness. Same eye, just looking at the ganglion cells, we can see rather significant loss of ganglion cell bodies throughout this entire inferior hemisphere. And we can also see the wedge defect, but I think it's more readily seen that there's a fair amount of damage looking at just the ganglion cell layer. And here is the point in this. If we're looking at macular thickness in the context of glaucoma, we need to keep in mind that if we're taking total retinal thickness, that can be influenced by a variety of other diseases. As we just saw, patients with epiretinal membranes, VMT, VMA, that's going to tend to distort total retinal thickness. Whereas if we're looking at just the ganglion cell layer or the ganglion cell complex, that particular sublayer of the macula is going to tend to be less influenced by the coexistence of other macular diseases. And now this brings us to looking at the optic nerve, particularly the neuroretinal rim, which in the days before we had OCT technology, this is where we concentrated. We looked very carefully at the neuroretinal rim. That's the basis of what we call the cup to disc ratio. So when we're looking at this neuroretinal rim, and we'll talk about the importance of Brooks membrane opening, we're talking about scans that are taken radially through the optic nerve. So we're not looking at scans around the optic nerve. We're not looking at scans over in the macula. We're looking at scans that are taken as radial cuts through the optic nerve. So imagine if this is our scan pattern, we're taking a series of radial cuts all the way around 360 degrees around the optic nerve. Now, the advantage to using this particular technology is what is very readily identified on OCTs are Brooks membranes. And the edge of Brooks membrane at the optic nerve is very easily seen. As we know, Brooks membrane is the basement membrane of the RPE. No axons. Remember, glaucoma is a disease of ganglion cells. None of these axons that are exiting this optic nerve are going to take a shortcut and dip down through here and ultimately end up in the optic nerve. Every one of those axons is going to make this 90-degree turn to get into the optic nerve medial to Brooks membrane opening. And in fact, the only tissue that's going to be medial to Brooks membrane opening are blood vessels in the optic nerve and axons of ganglion cells. So we can see very readily, and most importantly, we can measure very readily how thick these axons are in various sectors throughout the optic nerve. And that is very important in both quantifying how much nerve tissue we have, actually how much neuroretinal rim tissue we have, and over time, is that neuroretinal rim tissue beginning to erode? Now, here's a patient with advanced glaucoma. This is the Brooks membrane opening thicknesses in the 12. This is less than the number of scans that we usually do, but these are the 12 clock hours around this optic nerve. And this too is characterized or based upon a reference database. Notice each of these lines here is red, meaning that they fall outside of the normal ranges. Notice in particular, inferior temporally, we have very, very, very thin neuroretinal rim. So that means when we're looking at this optic nerve in vivo, we're seeing an eroded temporal rim. In fact, we're seeing pretty much lack of neuroretinal rim tissue here inferior temporally. The superior temporal sector is not a whole lot better. There is still some tissue here. So we would certainly expect to see an arcuate visual field defect. Superiorly nasally, there is erosion of the tissue, but there's a little bit more robust tissue here nasally than there is temporally. So that's why looking at the neuroretinal rim is very important. We also need to keep in mind that different instruments look at the neuroretinal rim in different fashions. Many folks are using a Topcon Maestro. Great instrument, works exceedingly well. On the right here, we can see the identification of Brooks membrane opening, and quite simply, the OCT picks up Brooks membrane opening here. It picks up Brooks membrane opening on the other side of the optic nerve. That gives us a reference plane. And what this is basically saying, or when we identify Brooks membrane, we are saying this is the size of the optic disc. Well, if this is the size of the disc, where is the optic cup? Well, the Topcon Maestro picks a reference point 120 microns anterior to this reference plane and calls this area the optic cup margin. So the optic cup using the Maestro is 120 microns anterior to the reference plane of Brooks membrane. And when we look at our Maestro scans, we can see this teal line, which represents Brooks membrane opening. In other words, this represents the size of the optic disc. And we see this purple measurement as the size of the optic cup. And that can sometimes get in the way of what we're seeing clinically. We're looking at this optic nerve, and we've all been down this road. We look at the optic nerve. We even do it with our own patients. We see a patient one year, we call them a 2x2. We see them another year, we call them a 3x3. We see them the next year, we call them a 1x1. We're the variable in measuring their cup to disc ratio. So the advantage to an OCT with measuring the cup to disc ratio is it's going to do the same thing each time. The difference is that each instrument does it in a slightly different fashion. So we might look at this optic nerve and say, well, hey, that disc looks like it's out about here, when in fact the OCT is saying, no, actually, this is the size of the disc because this is measuring Brooks membrane opening, and then this is the size of the cup. My point here is that when the instrument is determining a cup to disc ratio, it is seeing something that you and I can't see when we're looking at the eye in vivo, and that is Brooks membrane opening. Okay, here's an individual with elevated IOP and significant cupping in the right eye. This is a reference data plot of this patient's neuroretinal rim. Again, these are the Garway-Heath sectors. And notice when we get it down into this inferior temporal sector right here, there is very, very little tissue here. In fact, there's only about 49 microns of tissue remaining. And in fact, if we look even closer, this is a follow-up scan, and there's been a 9 micron decrease in this inferior temporal thickness measurement from baseline. And as we talked about earlier, that 9 micron difference in something that's only 50 microns thick is 10%. That would be rather significant. Okay. This is the patient's RNFL scan. We see some, again, we see 3 different circle scans of the RNFL. We see some thinning inferior temporally here. Not surprisingly, we have a visual field defect, the superior arcuate visual field defect. So this is a situation where the structure and the function are kind of matching up very nicely. Now we need to talk for a minute about deviation maps, and deviation maps are also statistical analyses of deviations from the expected outcome. And these are deviations that we would see in the full retinal thickness, that we would see in the RNFL, and we would also see in the retinal ganglion cell. So let's take a look at a case of a 66-year-old female who was referred in by primary care because of cataract. She comes in with pressures of 20 and 22. We look at the optic nerve in vivo. We see a 6x6 cup in the right and a 5x8 cup in the left, and packs are a little bit on the thin side. And let's concentrate on this individual's left eye and explain what these deviation maps are. With deviation maps, we can be looking at the entire retinal thickness. We can be looking at, as we are in this particular case, just the RNFL. And I think if we were looking at the RNFL, and this is a thickness map, not a statistical map, we would all agree that there is a wedge defect in the RNFL, in the axons inferior temporally. And this is the deviation from norm that we're talking about. So this would be the deviation map in the RNFL. In other words, we're saying that there's a whole sector, a whole wedge of axons that are much thinner here than we would expect. And they're certainly much thinner than they are in the superior temporal sector. Okay. Same individual, now we're looking at deviation map of the ganglion cell layer. Remember, we have all these axons over here that are missing. What about the ganglion cells? Each axon has a ganglion cell body that is located in the macula. So if we have axons that are missing here, we would expect to see ganglion cell bodies that are missing here, and that is exactly what we're seeing. This deviation map is very clearly showing the loss of ganglion cell bodies in the macula. And going back to the previous scan, if the cell bodies are located here, the previous scan shows us that it is connected to these axons here. So again, this is a situation where the pieces of the puzzle are all matching up. Now, another thing we need to talk about with OCTs, many OCTs are invoking and using the Hood report. Don Hood really came up with some great ideas in utilizing this, and it helps us in a couple of different ways. Number one, we see that the Hood reports use the end-stin graph, meaning that all of the scans, especially in the perioptic RNFL, of the temporal aspect of the optic nerve are in the center portion of this scan. Okay, so it makes it easy for us to see. If we're concentrating on glaucoma, we need to be looking here and not necessarily at the two ends of this scan. So in this particular Hood report on a Heidelberg spectralis, we have what are called the retinal views. This is anatomically correct. So we have an inferior temporal RNFL wedge defect. If we're looking at an axonal wedge defect here, we should have ganglion cell bodies over here that are defective, and that's what we see here in the ganglion cell layer thickness map. Okay, again, 2 and 2 is adding up to 4. This makes sense. But where the Hood report really comes in handy is it can help us to determine which type of visual field instrument or which type of visual field strategy we should be using. So when we're looking over here on the right side, we're now superimposing a 24-2 series of test points or a 10-2 series of test points over the posterior pole or over just the macular area. But keep in mind that visual fields are reversed anatomically from what we're seeing fundoscopically. So this is called the field view. This is the same image as we have here, except everything is reversed up and down. So here is that inferior wedge defect. Okay, so the inferior retina is up here, but this is showing us which points are going to be tested in a 24-2 or a 10-2 visual field. Okay, so if we do a 24-2 visual field, we're going to get a visual field that's really only going to pick up a couple of points here and there that may or may not be related to glaucoma. And my question to you is, how many times have we seen glaucoma patients? We run a visual field on them and the visual field looks relatively clean, or there are a couple of non-contiguous points. We see this quite often in early glaucoma, and maybe that's because we're using the wrong visual field strategy when we're evaluating these patients. Whereas if perhaps we used a 10-2 visual field, we would have more corresponding visual field loss associated with the structural loss in the ganglion cell bodies that we see. And that brings us to the topic of visual fields. We need to recognize that we have a problem in glaucoma, and that the visual fields that we've been using for years and years and years, especially in the context of early glaucoma, they tend to undersample the macula. And what do I mean by that? Let's take a look at this schematic. These are the test points in a 24-2 visual field. So we're plastering these areas of the retina with these little white spots every time we do a visual field test. But we need to recognize an important fact here is that the density of ganglion cells change the closer we get to the fovea. So when we throw a spot of light at this portion of the retina, we're only tickling 10 ganglion cells, okay, for each white test pot that we're using in a visual field. If we move closer to the retina, well, they're a little bit more compact here. So we're tickling 35 ganglion cells. And in fact, when we get closer to the foveal avascular zone or in the foveal avascular zone, we're now tickling 230 ganglion cells with the same sized spot of light that we tested out here. And that is important because if we look at the 54 test points that we're testing when we run a 24-2 visual field, and we recognize the fact that 50%, half of all of the axons that are in an optic nerve, half of them come from this central 20 degrees, we're really only testing, depending upon how you count it, 12 or 16 test points. So we're testing all these areas out here. The majority of axons have cell bodies that originate here. So we're clearly undersampling this central area of the posterior pole when we're running a 24-2 visual field. And that's why there's been a significant move toward running a 10-2 visual field. This was an interesting study published a couple of years ago. It was looking at 24-2 visual field testing, 10-2 visual field testing, and OCT technology. And for the purposes of this study, these were individuals who had early glaucoma. They had OCT damage that was clearly visible in the ganglion cell layer, and they underwent 24-2 and 10-2 visual field testing. And it was interesting that when they looked at the data, all of these individuals had structural damage, and those individuals that had structural damage and 10-2 visual field abnormalities, half of them did not have any 24-2 visual field defects associated. This goes back to my comment earlier. When we're running a visual field, especially a 24-2 visual field test on an individual who has early glaucoma, oftentimes the 24-2 visual field test is not showing us anything. And this study backs it up. It said that 50% of these individuals had clean 24-2 visual field studies. That's why there's been this move, as I said, toward 10-2 visual field testing in early glaucoma. So for years and years and years, we've been using 24-2 instruments. Maybe that's just been the wrong test to use. And now let's tie this together with structure and function. How do we tell when patients are getting worse? Does progression show up on the structural end of the equation? Does progression show up on the visual field end of the equation? Well, the answer is, again, a study that was recently published, a pretty good, well-designed study with a significant N, kind of gives us some very definitive clues here. And at the end of the day, in early glaucoma, okay, this is a series of OCTs of a patient and their visual fields in a patient with early glaucoma. This study, I think, conclusively showed that individuals who are going to worsen, individuals with early glaucoma who are going to worsen, we're going to be able to pick up that worsening on the OCT and not the visual field test. All right. What about patients on the other end of the spectrum who have more advanced glaucoma? How are we going to tell if they're getting worse? And it's just the opposite findings here. This is a series of OCTs and visual fields in a patient with advanced glaucoma. And notice over time, there's very little identifiable structural change on the OCT, but we can see progression of the visual field loss. And the implication here is that perhaps in patients with advanced disease, we need to concentrate more on the visual field rather than the OCT. Well, how can that be, Dr. Fanelli? Because OCTs are so doggone accurate. Why do we make this sudden change to now paying more attention to visual fields? And the answer is this is part of the floor effect. We can only thin an OCT measurement down so thin. Inferior temporally, for example, that neuroretinal rim case I showed you earlier, they were down to 7 microns. You can't get much thinner than 7 microns. So there's only so much structural defect that you can get before you run out of any more room for structural defect. And that's going to then show up in the visual field. So the point of this particular study is that in patients with early glaucoma, we need to consider paying very careful attention to the OCT as opposed to the visual field, whereas individuals with advanced glaucoma, it's just the opposite. Now, all that being said, the study that I was showing you earlier said that if we're using 24-2 visual fields in early glaucoma patients, we're probably going to be missing a lot of the field defects. So I'm going to go back to the previous slide. For example, in early glaucoma, notice these 24-2 visual field tests are relatively clean. I wonder what these test results would have looked like had they used a 10-2 visual field. I didn't design the test. That would be nice and interesting to know. And that brings us to some of the newer technology that we have from a visual field perspective. I think if we can have a show of hands, how many of our patients, especially our glaucoma patients who get a visual field once or twice a week, I'm sorry, once or twice a year, good God, hopefully not once or twice a week. How many of our patients who get visual field testing once or twice a year really enjoy that testing? Not many. Okay, there's very, very few people who enjoy that. And that's why there's been this move toward virtual reality headset visual field testing. And there are some distinct advantages. We are employing two of these particular instruments in our office. And I have to say that we've had the first one we put in January of last year, so we're a year and a half in. The second one was put in just a few months after that. And the number of visual fields that we're actually doing on the standard box perimeters has gone down to pretty much zero. And there's a couple of reasons for that. But here's the dilemma that I had. You know, I've got years of visual fields on glaucoma patients. And once you have that set of baseline information, it's hard to give that up, especially when you're flipping over to a new technology or a different technology. And the first question that I have is, okay, with these virtual reality or this particular ALA's visual field unit, am I going to get the same results? If you test a bunch of normal individuals on Monday, you're going to get a particular visual field for that individual on Monday. It should look the same as it would on Tuesday and Wednesday and Thursday. In other words, the retest results should be the same, whether they have glaucoma or whether they don't have. But most importantly, the other piece of the information that I need to know is, how does this compare to a Humphrey visual field, which is, as we know, the kind of the gold standard. It's been the gold standard for glaucoma management for years and years and years. So if we look at visual field testing, and this is test, retest, repeatability. In other words, in a perfect world, this test, retest line is going to be very, very tight, depending upon, how we do on the first visual field and how we do on the second visual field. So if we're looking at normals, I think the data is pretty significant that the test, retest, repeatability is there. If we're looking at the reproducibility of these visual field devices in glaucoma patients, the test, retest, and third test data is pretty significant when we're looking at a variety of different parameters in that visual field. And particularly, we'll look at mean deviation and pattern standard deviation. These numbers are pretty consistent in glaucoma patients. So that answered the first two questions that I had. If we flip over to this instrument, is it going to give us consistent results in the same patient? And the answer is yes, if they're normal, and yes, if they have glaucoma. Then the question is, well, okay, in individuals who have glaucoma, how does this new technology compare to Humphrey visual fields? And I think the test, retest data speaks for itself. But when you're comparing the testing and the results with this instrument versus Humphrey visual field instruments, that data is pretty consistent as well. So it made me feel better that if I'm going to make the switch to a different perimeter, I'm going to get comparable results. Okay, now there's some other advantages to this particular unit in that it does not only visual field testing, it does a variety of different visual field tests, in particular 10-2, 24-2, and 30-2 visual field tests, both in threshold and in screening modalities. It does ptosis bulb visual fields. And that's important because we waste a lot of time doing a visual field. Then we do the same visual field, we tie the or tape the patient's eyelids up. But it also does visual acuities, it does color vision, it does pupils, and it does EOM. So the initial uh, draw to me was the fact that you're going to be able to have your tech set this patient up with this instrument, and it's going to get a variety of data points that can be used. I actually don't use it as much for that as I do for the visual fields, because that's where I live in the glaucoma and neuro world. And this is what the visual field printouts look like. They look exactly the same for the most part as a Humphrey visual field. You've got pattern deviation, you have total deviation, you have your grayscale, you have your raw data points. It's pretty consistent. This is an individual with glaucoma in the right eye. This is the patient's left eye, entirely normal. This is obviously a 24-2. The headset is ultimately lightweight, but the kicker for me was the unsolicited comments from patients about how much more comfortable this was. And I never really thought about it from that perspective, because as we know, as we're running visual field tests on individuals, they have to sit forward in a certain position. One eye is tested, then the technician has to take the patch off, put it on the other eye. Interestingly, these visual fields with the all eyes unit are tested bilaterally. Both eyes are tested at the same time. Well, it's interesting. How does it do that? Well, I sat for the test, and basically one eye is seeing the fixation target. And this is going to be very important in individuals who have macular degeneration. In the eye with central vision loss from macular degeneration, they're not going to be able to see your fixation target. But if the other eye doesn't have macular degeneration nearly as bad, they're going to use their better eye to see that fixation target. And at the end of the day, the way the test works is that some of these test points are projected to the right eye, some of them are projected to the left eye. I, as a patient, couldn't tell a difference until I closed one eye or the other, and then I'd be able to see a difference. But assuming that they're keeping both eyes open, which they should be, both eyes are tested simultaneously. It cuts down on the test taking time, and patients are not hunched forward. So unsolicited across the board, the majority of patients are saying, well, I could do that visual field test much easier. I don't mind doing that. I'm not going to kick up a fuss every time you run a visual field test on me. We don't use a beanbag. But of course, the point here is that you're not tying up a room, and you're not tying up a significant amount of floor space with a box perimeter. So this can be done in an exam room. This can be done in a dilation and hold area. It could even be done in the waiting room, but they can have the visual field test done with relative ease. So hopefully we touched on a couple of key points, knowing the technology, perhaps giving you some ideas as to how to evaluate the patients, both from the RNFL perspective, the macular perspective, in particular ganglion cell layer, and then looking over at Brooks membrane opening, BMO, structure of the neuroretinal rim, and when we should pay more attention to certain visual field studies and how that correlates with our structural changes. So with that, I want to say thank you.